and fellows coming here today to acknowledge Dr. Belaish, which is amazing to organize all this meeting every year. So thanks again. So in the next minutes, we're going to talk about bone tumors in children and what we should know. So it's a wide topic, so I tried to do my best to focus on the main points. So first of all, I'd like to emphasize that the radiologist's role is essential in the work up and staging of bone tumor, but it has to be part of a team with oncologists and surgeons. So our role is mainly to provide a meaningful report to take care of the kids. So concretely, you have 4 situations about bone tumors. You can have normal findings or almost normal findings with persistent symptoms. So you should always think about bone tumors. It could be easier for you if you have abnormal findings on X-rays or other imaging studies. And sometimes you have multiple abnormal findings. So the first question to ask is it malignant or does it look malignant or not? The first part of my topic will be focused on benign lesions. So I'm not going to describe all the benign lesions because it's going to be way too long and too boring for you. So I'm going to only focus on what you should absolutely know and what we call don't-touch lesion. Don't-touch lesions are typically 100 or 200% benign lesions that you must know in everyday practice. So we have I'm going to let you work a bit too. So here is a typical case of 2 different patients with the same lesion, where you can see here on the phalanx, it works here. Yeah. You can see a lytic lesion involving the first phalanx here, with endosteal erosions here, with tiny calcifications. Here we have the same lesions where we can easily see all the calcifications. So we're dealing with metaphysis lesions involving long bones or phalanx with calcification, possible complication like here in this example with a fracture, and this is typical with enchondroma. Second kind of lesion I want you to know is this lesion. So it also involves the metaphysis here. Sorry. Here, it's asymmetric and eccentric with a cortical base here that you can easily see on this example. And the lesion is growing according to the long axis of the bone with a big sclerotic rim here. So we're dealing with a metaphysis lesion with sharply and well-defined margins here with a thin rim, which was typical of non-ossifying fibroma or cortical defect. The difference is based on the size and it's not recognized by the pathologist. That is only the same lesion with same cells, but only with a different size. So let's move on to another don't-touch lesion. Here is another example. You can see metaphysal lesion 2 that grows away from the metaphysis here, oriented here on the long axis of the bone. And the main clue here is that you have a continuity of the cortex here to the lesion and also a continuity of the trabeculae going through the lesion. This was typical of exostosis or osteochondroma. In our patients, it was a bit different because, like you have noticed, you have also different locations like here, or here, or here. So it's what we call Bessel-Hagen disease or multiple exostosis. Another example of the typical classical don't-touch lesion is here on this red area of lucency here on the calcaneus with a thin sclerotic rim here. And here it's the same lesion with a different location. So this was typical and what we should know. So it doesn't look really aggressive here. And this was typical of a simple cyst. Another example here of a 6-year-old girl with soft tissue swelling of the right thumb, with here on the X-rays an expansile lesion here, of the first metacarpal bone with respect of the cortex. Further studies were performed. Here you have CT recons on coronal and coronal study of MRI and T1, where we can see that we have a lesion involving the whole bone here, and solid lesion here, which was typical because of the location and the benign appearance respecting the cortex here of a solid ABC or solid aneurysmal bone cyst. Again, just want you to know all the essentials, so it's not a big, huge list, but you have many things to know about tumors. So this was another example of a 12-year-old teenager with a diaphyseal lesion here of the tibia, eccentric, multiloculated, like we can see here, but with a rim around here. Here is... okay, it looks better on my screen, but you can see the magnified picture here. Here is the corresponding CT. So you can see all the findings here better on CT with the cortical thickening here and the rim around the lesion. But here you can see that the cortex is disrupted, but not the periosteum. This was typical of an adamantinoma, which was also typical because of the location. It was part of the tibia, so it's a must know. So this lesion was part of the same spectrum like osteofibrous dysplasia or non-ossifying fibroma. All of this lesion has a same pathology continuum, and you must know them because it's really, really common. And just you can easily speak about adamantinoma, or osteofibrous dysplasia when it's located on the tibia, like here is this different example. So another case here of 10-year-old female with an expansile lesion involving the metaphysis and the superior third of the tibia here, with expansion here, but the cortex is still not disrupted. You can see some trabeculations within the lesion. Further studies were performed. Here, CT and the corresponding MR. On the CT, it's really tricky because you can see a large area of lysis with no real sclerotic rim around. And here on the MRI is characteristic of the lesion because you can see, recognize the trabeculation that you saw on the Xrays here and the fluid levels, which were consistent with a small bone cyst. So another case, 10-year-old male with leg pain. So let's get back to Caesar what's his due, because my brilliant colleague found out this area of lucency here. I'm not sure I would have seen it, honestly. So she asked for further studies, and but what we get on the CT scan, so she's really brilliant. She couldn't make it today, but it's her job. So you have an area of lucency here involving the distal fibula here with the adjacent cortical thickening. Do you have an idea what it could be? Yes, Laurence. So here's the corresponding MRI. It was done just for iconographic purpose, but we're here to learn, so that's perfect. We have coronal and axial images of the distal leg, where you can see a large area of edema involving the fibula and the adjacents of tissues. And also you can recognize that the area of lucency here, well defined on the T1 with the cortical thickening, and this was of course consistent with osteoid osteoma. So all these lesions were pretty common, and you must know the main features not to continue further investigations. So now we're going to move on to the second part of the lecture and go to malignant bone tumors. So again, it must be general because I don't want you to be bored. just a few epidemiologic features. So malignant bone tumors represent 6 to 10% of cancers of children, so it's not rare, and you must know the most features. So the frequency peak is during teenage age, and osteosarcoma and Ewing sarcoma represent 90% of all. So we don't want you to perform a histologic diagnosis. We want you to describe it as malignant, and this is the pathologist's job to give us the clues about the specific tumor. So these tumors are really aggressive. So whenever you think about a malignant bone tumor, you got to perform all the studies really quickly. It has to be done on the next day, or at least in 2 or 3 days, because they're fast-growing tumors. So you got to be really do things quick. So I'm going to try to give you some clues to avoid traps and tricks in malignant bone tumors. We're going to start with the clinical findings. So some findings are pretty uncommon in kids, especially when you have inflammatory pain associated or not with tenderness. You got to be aware of the possibility of a malignant tumor. So never reconsider the diagnosis, because like we know, all the kids have trauma, but it could be associated and it could be a pathologic fracture. Just I want to emphasize this point. So let's start with this case of a 13-year-old male with left sciatica. So we have a pelvis radiographs here, an AP view. So can you see something here? Okay, so just a few words about X-rays. X-rays are essential, but there's a low sensibility for long bones, and the sensibility decreases for axial skeleton, especially for pelvis, because you have a lot of gas, and it could be really tricky for you. So whenever you have uncommon symptoms, like here, it's really uncommon to have a sciatica for a teenager. So whenever it happened to you, you should go further on. So here is the corresponding MR. So where we can easily see now, but you have to do the MR first, of a dark lesion here with ill-defined margins involving the left sacral bone and extending to the soft tissues. So this was an osteosarcoma. I can show you back the X-rays. It was not easy at all, but just focus on the clinical findings. Second trap is to recognize a malignant bone tumor. So you need a thorough semiotic analysis to rule out aggressiveness. You have a lot of clinical, radiographic findings that you know, like lysis, like you gotta search your sclerotic margin, and anytime you have a doubt, just go further on. You won't be sued if you have a CT or MR for a kid, never ever, so just go ahead. So X-rays are the first study to perform because it's inexpensive, and a lot of differential diagnoses are performed on X-rays, especially benign lesions. Just keep in mind that you need to lose 50% of the normal mineralization, before being allowed to depict a lesion. So just keep in mind, just because it's normal that you don't have anything. So many malignant features could be recognized on X-rays. Here is an example where you can see a really aggressive appearance with sunburst appearance and a Codman triangle here, where you can see that the periosteum is here moving out of the bone. When it's like this, it's pretty easy because it doesn't look good. But sometimes it's really tricky and less easy for you. Here is an example of a 17-year-old female with a pain that started 1 month ago and soft tissue edema. Can you see something here on your X-rays?
Cortical.
Yeah, you have a puffy appearance here of the cortex, but it could really easily be missed. So we saw it too, and that's what we did. So here is the corresponding